Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hello, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi. James, let's talk more adjuvant therapy, CheckMate 76K, but maybe just a few rapid fire questions. Tell us the name of the town where you grew up.
I didn't even grow up in a town. I grew up in a very small village in North Cornwall called Port Isaac Fishing Village. So,
okay.
Yeah, tiny little place.
Okay. Did you live on an actual street?
Yeah. As opposed to what name of the street that I lived in. Yeah. And until my mother lived there until very recently, it's called the Terrace. It's a terrace of houses which look out over the Atlantic Ocean, actually. So, looking kind of northwest anyway. So in fact, the first land you would come to the west would actually be the eastern coast of the US.
Oh, wow. How nice. I was trying to get at a question that now probably isn't going to make much sense if you lived at the Terrace, is the name of your street. So I was trying to get to, have you heard this thing, like what would be your porn star name? Which is the name of your first pet, and then the name of the street that you grew up on.
Yeah, that wouldn't work that well.
Oh, bummer. Mine I'll answer it then, because mine actually is quite cute. I think mine would be Lucky Westridge, which I think sounds like a teenage detective novel, right? Yeah. The Lucky Westridge, detective series. I don't know. But that means that's also my sister's porn star name, because obviously we have the same animal in the street. So you share it with all your siblings.
Yeah. Yeah, true enough.
Okay.
Right. So
quick fire. Let's get into 76K, shall we? Okay, why don't you tell us about the CheckMate 76K study?
Yeah, I mean, one way to just think about this easily, I suppose, is to say it's quite like Keynote 716, but with Nivolumab. So in other words, we're talking about stage 2 melanoma resected stage 2B, 2C, placebo-controlled trial, actually 2-to-1 randomization of Nivolumab given every 4 weeks, or placebo for 12 months, primary endpoint, recurrence-free survival with standard secondary endpoints. And so presented at a meeting, I guess last year or maybe even the year before, can't remember, published in Nature Medicine, October 23. John Kirkwood was the lead author. And I guess the headline for me is that the hazard ratio actually for RFS was just over 0.4 with a confidence interval, 95% confidence interval, 0.3 to 0.6, basically. 12-month landmarks of 89% versus 79%. So a kind of a difference at 12 months for 10%. So hazard ratio actually numerically superior, if you like, to Keynote 716, but actually in the same ballpark for me. And so I really see it as being a confirmatory result and very much consistent with Keynote 716.
That's a good point to make, because I think when the study was first presented, there was an overinterpretation of that hazard ratio. In comparison to 716, the hazard ratio never dipped below 0.5. It was always in that 0.6 range. And some people said, oh, if the CheckMate 76K has a hazard ratio of 0.4, 0.42 or whatever it was, then perhaps that's signs of stronger efficacy. But that's really just an overinterpretation, and we really only saw 12 months of follow-up, right?
Yeah, I mean, is that really the most biologically plausible explanation, is what I would say here. Is there anything, just to try and run this to ground, is there anything that we know already or we'd seen in other contexts suggesting that there was a difference between these two drugs? No, there wasn't. So, for me, that's a statistical variation until proven otherwise. That's absolutely how I see it.
So if you feel that there may be no difference between the 71676K sort of overarching data and no real difference in your hands as far as the drugs, how do you choose between an adjuvant PD-1 use of Pembro versus Nivo in this setting?
We've always been driven by pragmatism and to some extent reimbursement as well. So that the reimbursement, actually, I can't complain too much, but it's not as quick as the US. But going right back to the very start, I think Nivo was the first drug that we had for metastatic disease, and it was 2 weekly. And then Pembro came along again for metastatic disease, and it was 3 weekly. So we, again, same argument. The drugs are extremely similar. We switched to Pembro 3 weekly because actually it's better for patients. Number one, come to the hospital every 3 weeks. It's better for our day unit and our pharmacy and everything else. Then subsequently Nivo becomes 4 weekly. Then we switch back again to Nivo. And this, of course, assumes that we're using them in interchangeable indications as well. There are there's a few nuances around that. And then Pembro 6 weekly.
Yeah.
And so then, then we would go to 6 weekly. So that's really our driver. Again, you could ask the question, do we really know that all these different schedules are the same as each other in terms of efficacy and safety? No one's done any randomized trials of this stuff, for example. But nevertheless, I think I'm sufficiently reassured by what has been done to be comfortable giving, let's say, Pembro 6 weekly if I'm giving single agent anti-PD-1.
Yeah, if I may make 2 comments on that, and then maybe I can ask you a final question. So my one comment is with 6 weekly dosing, I think it is really, really convenient. But I think the concern for anybody who's starting to use these drugs is that somebody could pop into your clinic. It could happen, and it happens uncommonly, but when it happens, you will feel very burned by it. They will show up for their second dose or third dose at a 6 weekly interval, and their LFTs will be right out of control. And you will be scrambling. And as you and I have talked about, that's where a light touch of steroids is better. Certainly you don't need 2 milligrams per kilogram or even 1 milligram per kilogram. However, you will then start to feel nervous and, you'll have a light touch of steroids, but a heavy touch on the patient. And so sometimes with 6 weekly dosing, what I do is 3 weekly at the beginning of a tox check. So I just have them come at 3 week mark just to look at their LFTs, look at their whatever else, just symptoms, their rash, whatever. And we can still dose it at the 6 weekly if it's a reimbursement issue. We used to have this issue of if you started out at 3 and switched to 6, it was different insurance approvals. Now it all appears to be one insurance approval. But, if that's a concern, then just keep them at 6 weekly, but just bring them in a little more often upfront until you understand how they're tolerating it so you don't get necessarily behind. Though rightly that transaminases can happen at any time. It doesn't have to be an early toxicity. That's my one point. The second point, I've forgotten. So let me grab my thought here.
Why don't I say something about that? I'll respond to that while you're thinking about that again. I agree. We're using quite a lot of 6 weekly Pembro in kidney cancer, but then there is adjuvant, and I'll come back to that in a minute. But if you're using it for advanced disease with lenvatinib, for example, you're going to be seeing those patients a lot in the first 6 weeks because you need to get the lenvatinib dose right. So that sort of isn't really an issue. But let's say in the adjuvant kidney 6 weekly Pembro or melanoma, I think this is an important point. Maybe just in the first cycle. Of course, you're right that side effects can happen anytime, but it just maybe feels a little bit like there's a group of people who, really can get significant side effects in the first few weeks. And I must admit, I'm not prescriptive about this in terms of doing a 3 weekly blood test, because I think that's the important thing. I think if you've got, for want of a better term, a sensible, compliant patient, if they've got a bad rash or something like that, or they're ill, I'd like to hope that they will ring up. But I think having the blood test done at least, and I think it's mainly going to be liver function, although I would say that there might be the odd patient who gets into thyroid trouble at 3 weeks. Again, it's probably going to be asymptomatic, but you do see that. And actually, one of the worst side effects I can remember seeing in the last year or two, and actually this was adjuvant renal, was nephritis. Very, very early nephritis. And actually, we happened to do the blood tests, honestly, for another reason, 3-4 weeks or something like that, and then you're in different units, so it won't translate that well, I think. But the serum creatinine was around 800. I don't know how that plays in US units, but that's 10 times the upper limit of normal, basically.
Okay.
Yeah. So the interesting thing was actually with this patient, he comes for another reason to have blood tests, some other routine appointment, and then we do the creatinine, and first of all, we just don't believe it, obviously, because he's looking completely well. And then we check it again, and then we admit him to hospital. And even then, I go and see him on the ward, and the guy's sitting there going, why am I in hospital? So, that maybe all of that's a long-winded way of saying I think there's probably a fairly strong argument for at least doing a blood test at 3 weeks in that first interval for people on 6-weekly treatment. So you should have now had long enough to remember what you were going to say.
I did, yeah. So, one comment about this nephritis thing, I think there is some evidence that nephritis can be a critical toxicity, and it may be happening early. It can certainly happen at any time course. So, and patients often won't necessarily clue into any symptoms if their creatinine is moving. There is some research that has been done at this at various locations. Some of this nephritis immune toxicity has been in the news, you may have seen, but for other reasons. So no need to really bring that up here. But what I will say, my question or my point I was going to make is I will often teach fellows that in this adjuvant setting, I had a couple of denials early on that have sort of adjusted my practice. If I had given a patient adjuvant nivolumab, this was when it was only had a stage 3 indication. If I had given them adjuvant nivolumab and then that patient developed distant metastasis and I wanted to use combination ipi-nivo, there was an occasion where I had an American insurance company say, we will approve the ipilimumab, but not the nivo. You have already given them the nivo. They're progressing through it. So that had kind of swayed me to use pembrolizumab in the adjuvant setting. Therefore, when I wanted to use ipi-nivo, I could be free and clear of that sort of denial. It just takes 1 or 2 of these that derails your whole workflow, having to argue with an insurance company or a peer-to-peer.
Yeah.
So that's just one thing. I haven't had that in years, so I think it's gotten better and smarter, but that's just my one caveat of everything else being equal and, intervals and things like that. And somehow I kind of like the Nivo every 4 week, but I'll probably stick with Pembro every 6 and those early toxicity checks. I liked the Nivo because it was you just had that regular touch on a patient, but the 6 weekly makes sense too. I guess maybe a last question, because there's probably not a whole lot more to say about 7/6K in particular, but what do you make of maybe novel formulations of these things? What happens when we get a sub-Q formulation? Would you ever be in favor of patients maybe self-administering their doses and then popping in to get blood or having blood dropped off for review?
Yeah, I think this might not be quick, actually. I think this is obviously the direction of travel. There's probably quite a few different points to make here, I think. One is that the patent lives are coming up pretty soon on nivolumab and pembrolizumab given intravenously, and we know that subcutaneous formulations are in development, and there's some data out there as well, actually, and we know already that other monoclonals, Herceptin probably, and atezolizumab may be the best examples. They're out there, they're available. So I think from a patient perspective, potentially that's great, but it does slightly assume that the subcutaneous formulation is going to be relatively tolerable. I'm not an expert on this area, but sometimes they're quite large volumes. You can get injection reactions, and if you've got someone who's got relatively easy intravenous access, and they're coming up to the hospital anyway, actually sitting and having a 1 hour infusion might not be too difficult. Usually with the subcutaneous formulations, you'd sort of assume it was get injected and that would be it. It's not like that from what I know. It actually takes quite a few minutes. But, I'm sure there'll be progress on that. And I think it does open up the door for people not needing to come to hospital for treatment fairly obviously. They could be treated at home by community nurses. They could maybe learn how to do it themselves. And then you have this disconnection by how the treatment is being given and where the treatment is being given from how you want to monitor the patient, which I think, and we just sort of touched on that a little bit already with the 6-weekly Pembro. So I think you need to be really clear in your own mind how often you want to see that patient. And some of this could be virtual as well, actually. I think that could work. and how often you want to do safety monitoring. So I'm pretty positive about all the subcutaneous formulations in general. And then I guess the other part of this is the question of what level of evidence is required for different formulations for them to get regulatory approval, which is a regulatory question basically, and certainly that's all the trials are ongoing at the moment to demonstrate equivalence. So it's happening.
So, James, why don't you just wrap up 76K for us? Tell us the key takeaways here.
Yeah, so CheckMate 76K, adjuvant nivolumab versus placebo in stage 2B and stage 2C melanoma with negative lymph node staging, showing clear benefit in terms of relapse-free survival and distant metastasis-free survival, and a relatively early readout at the moment. But for me, the data look equivalent to Keynote 716, and I think that means that either Nivo or Pembro mono are potential options in this group of patients.
Sounds good. And the singular publication in Nature Medicine in 2023, good on them for getting it in such a good journal.
Congratulations, John and colleagues.
All right. Take care, everybody. See you next time.